Oncology 12. Breast cancer. Breast cancer is found in asymptomatic women on screening mammography or by palpation of a mass by the patient or physician. When breast cancer presents as a palpable mass, it is hard to touch. It may also be associated with retraction of the nipple because ligaments in the breast will withdraw and pull the nipple inwards. Breast cancer is usually painless. Diagnostic test. Biopsy is the best initial test. The different methods of biopsy are fine needle aspiration, breast needle biopsy, false positive rate less than 2%, but because FNA is a small sample, these advantages are a false negative rate of 10%. Core needle biopsy, larger sample of the breast can test for estrogen receptor, progesterone receptors, and HER2 test new. Disadvantages are greater deformity of the breast and the possibility that the needle will miss the lesion. Open biopsy is most accurate diagnostic test allows for a frozen section to be done when apparent in the operating room, followed by immediate resection of the cancer, followed by sentinel node biopsy. And FNA cannot test for ER, PR, HER2, or NU. Mammography. Mammography is indicated to screen for breast cancer in the general population starting at age 50. Woman finds a hard, non-tender breast mass on self-examination. There is no alternation of the mass with menstruation. She is scheduled to undergo an FNA biopsy. This one is most likely to benefit this patient. A. Mammography. A breast biopsy is going to be performed. Why do a screening test like mammography? The answer is that 5 to 10% of patients have bilateral disease. In addition, there is a huge difference in management of disease as a single lesion or multiple lesions within the same breast. Brca testing confirms an extra risk of cancer compared to the general population, but will add nothing to a patient who must already undergo biopsy. Ultrasound is useful in evaluating whether masses that are required equivocal by clinical examination are cystic or solid. Bone scan is used after diagnosis of breast cancer and made to exclude occult metastasis. PET scan helps determine the content of abnormal masses within the body or in large nodes without biopsy, but it does not eliminate the need to establish an initial diagnosis with biopsy. MRI is used in young women with dense breasts. The precise utility of MRI for breast cancer is not yet clear. When is ultrasound the answer? To evaluate clinically indeterminate mass lesions, it tells cyst versus solid lesions. Answer: ultrasound if the lesion is painful, varies in size, or pain with menstruation. When is PET scan the answer? To determine the content of abnormal lymph nodes that are not easily accessible to biopsy. Cancer increases uptake on PET scan. Suppose a 80-year-old woman with a biopsy-proven breast cancer has no nodes with cancer in the axilla. The primary lesion is small and the woman may not need adjuvant chemotherapy. Test CT shows an abnormal higher lymph node. In this case, PET scan is useful to exclude the need for additional chemotherapy. How do you tell the content of an abnormal inaccessible lesion without biopsy? Try PET scan. When is BRCA scan testing an answer? BRCA is definitely associated with an increased risk of breast cancer, particularly within families. BRCA is associated with ovarian cancer and pancreatic cancer. What is not clear is what to do when BRCA is positive. BRCA has not yet been shown to add mortality benefit to use in management. However, some patients opt for bilateral mastectomy. We do not know what to do about BRCA when it is positive. With so many methods to lower mortality in breast cancer, the step 2 exam will not engage in speculation about who should be getting BRCA testing. It is just not clear. When is sentinel lymph node biopsy the answer? The first node identified near the operative field of a definitively identified breast cancer is the sentinel node. Contrast or dye is placed into the operative field and the first node identified that it travels to is the sentinel node. Sentinel node biopsy is done routinely in all patients at the time of lumpectomy or mastectomy. A negative sentinel node eliminates the need for axillary lymph node dissection. When are estrogen and progesterone receptors tested? Always. These are a routine for all patients. If either test is positive, hormone manipulation therapy is done. Treatment: surgery, lumpectomy plus radiation is equally effective in efficacy to modify radical mastectomy, but much less deforming. The addition of radiation to lumpectomy is not a small issue. Radiation at the site of the cancer is indispensable in preventing recurrences in the breast. Lumpectomy is contraindicated if the cancer is multifocal or if radiation is contraindicated. Radical mastectomy is always the wrong answer. Side effects: tamoxifen, selective estrogen receptor modifier, endometrial cancer and clots, aromatase inhibitors inhibit estrogen effect everywhere, including food effects like bone density, osteoporosis causes. Hormonal manipulation: all ER or PR positive patients should receive tamoxifen, raloxifene, or one of the aromatase inhibitors, anastrozole, letrozole, artemisinin, stain. Aromatase inhibitors seem to have a slight superiority in efficacy, and both are among the answer choices. Aromatase inhibitors are the answer to the most likely to benefit the patient in question. Aromatase inhibitors are generally for postmenopausal women, while tamoxifen is better for premenopausal patients. Tip: if two treatments are very close in efficacy, how can you be tested on them? You will need to understand the differences in their adverse effects. Trastuzumab is cardiotoxic. When is trastuzumab the answer? All breast cancer should be tested for HER2/neu. This is an abnormal ER. Those who are positive should receive anti-HER2/neu antibodies known as trastuzumab. Trastuzumab decreases the risk of recurrent disease and increases survival. When all three receptors are negative, the chemo to give is atezolizumab. When is adjuvant chemotherapy the answer? When lesion size is greater than 1 cm and when positive activated lymph nodes are found. Adjuvant chemotherapy is not prophylactic. If patients already have the disease, it is not treatment since the term applies that there are no clearly identified metastases. Adjuvant means an additional therapy to clean up presumed microscopic cancer cells too small an amount to be detected. Use SERMs or aromatase inhibitors when multiple first-degree relatives have breast cancer. It lowers the risk of breast cancer. Also find definitely lower mortality, mammography, ER testing than tamoxifen/raloxifene, aromatase inhibitors, adjuvant chemotherapy, lumpectomy and radiation, modified radical mastectomy, trastuzumab, anti-HER2/neu, prophylaxis with tamoxifen or raloxifene, atezolizumab. Prostate cancer. Prostate cancer presents with obstructive symptoms on warning similar to benign prostate hypertrophy or palpable lesion on examination. Biopsy is the best initial test and the most accurate test. Most prostate cancers are asymptomatic. Gleason grading is a measure of the aggressiveness or malignant potential of prostate cancer. A high Gleason grade suggests a greater benefit of surgical removal of the prostate. If the Gleason grade is high, get it out before it metastasizes. Treatment: prostatectomy may have a slight benefit over radiation in terms of survival, but it has some common complications: erectile dysfunction, urinary incontinence. In localized prostate cancer, it is not known whether prostatectomy, external beam radiation, implanted with radiologist pellets, or watchful waiting is superior. Hormonal manipulation not like tamoxifen in breast cancer. They do not prevent recurrences but rather shrink lesions that are already present. Flutamide, GnRH agonists, ketoconazole, and orchiectomy help control the size and progression of metastases once they have occurred. Abiraterone is an inhibitor of 17-hydroxyurease that stops production of all androgens in the body, including adrenal production of androgens. It decreases the progression of metastatic prostate cancer and reduces risk of death by 30%. Exam questions about adverse effects are always clear. You will be expected to know the surgery is more likely to give erectile dysfunction compared to radiation. Radiation also leads to diarrhea. Hormone manipulators such as abiraterone, enzalutamide, and apalutamide lower mortality in metastatic prostate cancer. Management has definitely not benefited in prostate cancer. These answers are always wrong. Screening imaging study. Prostate ultrasound is not a screening test. It is used to localize lesions to biopsy when PSA is high. Lumpectomy. Chemotherapy is used only if hormonal therapy does not work. Hormonal manipulation to prevent recurrences is used only to shrink existing tumors. Prostate-specific antigen (PSA). PSA corresponds to the volume of cancer. The higher the PSA, the greater the risk of cancer. However, PSA is a controversial subject for the following reasons. Normal PSA does not exclude the possibility of prostate cancer. There is no clear mortality benefit with PSA. PSA is not to be routinely offered to parents. A parent errors and drive to not do the test even if asked. Tip: if the exam question specifically says the parent is requesting PSA to screen for cancer, then the answer is to do the test. Elaborated PSA algorithm. Evaluate PSA, palpable mass, biopsy the mass, no palpable mass, transrectal ultrasound, mass seen, biopsy the mass, no mass seen, multiple blind biopsies. Lung cancer. The most important question for lung cancer is who should be treated with surgery. The size of the lesion is not the most important factor and whether the lesion is resectable. If the lesion is large but is surrounded by normal lung and there is enough remaining lung function post-resection, then surgery is still possible. Surgery is not possible in these cases. Bilateral disease or lymph nodes involved on opposite side. Malignant pleural effusion, heart, carina, aorta, or vena cava is involved. Small cell cancer is considered unresectable in 95% of cases because it is metastatic or spread outside one lung. Screen for lung cancer annually with low-dose chest CT in those with 20-pack history years smoking, history age 50 to 80 years. When the question describes lung cancer that tests positive for the programmed death biomarker, not specific histology, the answer is pembrolizumab and nivolumab. These PD inhibitors are more effective and better tolerated than platinum therapy for non-small cell lung cancer. Mesenchymal masses, anterior mesenchymal masses, posterior mesenchymal masses, teratoma, thymoma, thyroid, and lymphoma, posterior mesenchymal masses, neophrobromas, and esophageal cancer. Mesothelioma. Mesothelioma is cancer of the covering of the lungs, peritoneum, or pericardium. Most 80% are associated with asbestos exposure. However, when the question asks what cancer is most often associated with asbestos, the answer is lung cancer, but lung cancer is so much more common than mesothelioma. Patients with mesothelioma typically present with the symptoms of pure inflammation and effusion, such as chest pain, dyspnea, and cough. Next unusual test, chest X-ray, then chest CT. Most accurate test, pleural or peritoneal biopsy. Management, surgical removal of the cancerous tissue, and in some both radiation and chemotherapy. Pleurodesis is a procedure to seal shut the pleural space in those with recurrent large pleural effusions. And pleurodesis, the pleura is purposely inflamed with minocycline, pneumycin, or thallic to obliterate the pleural space. Ovarian cancer. There is no screening test for ovarian cancer. Look for a woman aged greater than 50 with increasing abdominal girth who is still losing weight. PRC is associated with ovarian cancer. The best needle test is an ultrasound or a CT scan. The most accurate diagnostic test is a biopsy. CA-125 is not for screening, it is used only for follow-up of treatment. Ovarian cancer is the only cancer in which removing large amounts of locally metastatic disease will benefit the patient. Removing all visible tumor and pelvic organs and give chemotherapy, PARP inhibitors are especially effective in ovarian cancer. Cervical cancer, see the gynae section for evaluation and management. Testicular cancer. Testicular cancer presents with a painless lump in the scrotum that does not transilluminate. Risk is increased with history of hypercortisonism. Treatment is to remove the whole testicle with inguinal orchidectomy. Do not cut the scrotum, which can spread disease. Needle biopsy of the testicle is always a wrong answer. Grip orchid leads to cancer. Alpha-fetoprotein is secreted only by non-seminamatous cancer. SGT is elevated in all of them. Staining is performed with CT scan of the abdomen, pelvis, and chest. Testicular cancer metastasizes up through the lymph channels, lymphatic channels in the retroperitoneum, and moves up into the chest. After orchiectomy, radiation is used for local disease, and chemotherapy is used for widespread disease. This is referred to seminoma. Testicular cancer is one of the only malignancies in which chemotherapy can cure widely metastatic disease, including when it has spread into the brain. Seminoma is sensitive to chemotherapy and radiation. Non-seminoma is sensitive to chemotherapy. Chemotherapy-induced nausea. The three main classes of medications used to treat chemotherapy-induced nausea are 5-hydroxytryptamine inhibitors, neurokinin-1 receptor antagonists, and glucocorticoids. All three types of drugs can be combined in severe nausea and vomiting from chemotherapy. 5-HT inhibitors ondansetron, gianicetron, dolasetron. The answer to best needle therapy question. Exception: do not give a QT prolongation on EKG. Good exam question. Glucocorticoid, dexamethasone used first. Steroids have major anti-nausea effect. Combination with steroids effective only with 5-HT inhibitors. And neuroclear receptor antagonist, a precipitant, rolapitant, netopitant. The answer: 5-HT inhibitors do not work or cannot be given because of QT prolongation on EKG. Do not give 5-HT inhibitors with QT prolongation on EKG. The question about antiemetics that work through dopamine receptors will describe a patient whose Parkinsonism gets worse. The phenothiazines, chlorperazine, and chlorpromazine are antiemetics that are less effective than 5-HT antagonists. They will be the wrong answer choice in questions about chemotherapy-induced nausea. Metoclopramide is useful for nausea of diabetic gastroparesis. These medications have no utility in combination because they are all dopamine receptor antagonists.